This notion of gender health and sort of gender wellness is a concept that's helpful because, if you think about a school system, for example, and there's one trans-identified kid, and then all of a sudden there's an assembly to learn about trans stuff, and everyone knows it's about that kid, and that kid doesn't want the assembly to be about that kid, right? Or that one staff member at the nonprofit doesn't want everyone talking about how to best interact with them, right? And yet we still need to learn. So it's sort of a tricky thing. But so the goal is kind of like the broader you can get your reach and kind of cast the net around, is there room for everyone? And sort of do this, not like a cliched, oversimplified inclusivity model, but really like, is there room for variance versus sort of normal versus abnormal, right? And so the shift is more like, conceptually, you turn to this idea of a continuum of variance in general, and get away from what are the specific needs of this one person. What bathroom do they need? What locker room do they need? I mean, those points of advocacy are important, but the goal would be, it's simple edits that people fall to out of habit. In young, early childhood settings, it's going to be things like the boys line and the girls line. I mean, these things still exist, and they exist in the Bay. It's not like we've, transcended, and we're even in our bubble, we struggle with kind of these basic structures, and so there's plenty of place. And so it would be like everyone's going to make it to art class even if they're all on the same line, or it's like those kind of things. But and then there's language suggestions, like you can say children or folks or everyone that loves butterfly socks, come line up over here. So there's ways to kind of just get creative and expand, and often it's a really well-meaning but sort of habitual sort of default that we go to, and then the few kids that don't really fit are the ones that really notice, right? So there's that. Okay, so I just talked about that. I'm going to skip that. And so we just automatically, there's a lot of the long-term studies that show just even how infants are interacted with based on what the perceived gender is. And so it starts very early. Okay, so gender affirmative premises. The idea would be that gender variation are not disorders, that it's varied across culture and diverse, that it's an interweaving of body, psyche, and society, that it's not binary but fluid. Dysphoria is the specific diagnosis that needs to exist for treatment based on insurance to be approved. So whether that's a medical intervention or psychological services, both. And it's like anything else. It has limitations, and then it also can provide somewhat of a roadmap to understand if you think someone falls within a certain conceptual category. And of course, it's going to have limitations in terms of not everyone's going to fit precisely in a box. And then what do you do when they admit they're not that distressed by their body, but they still feel clear they know who they are? It's like, so there's this sort of like urgency to gather evidence to prove the diagnosis, and it's, there's a little bit of an ambulance chasing approach with that, so that we feel more calm about offering service or justifying service. And of course, that's like a system-driven thing, and you can lose sight of the child and the youth when you do that. And so anyway, if we get together another day, we can talk a lot about, how do you get creative and support whatever the actual presentation is and still understand how dysphoria can exist, because at a psychosocial level, there's huge amount of pressure on these kids. And so dysphoria can exist even if they're not having a specific distress of the body. And then family acceptance is really the bottom line. From a family systems perspective, my experience over my 20-year career is that, even a lot of really skilled, well-meaning clinicians will too quickly dismiss the family's capacity to show up, and there's not enough room for grief and pushback and fear and all of the things that are sort of the typical range of emotions. and they might be holding misinformation, or they might be worried they're going to lose their family or community and all those kind of things. And so there's not a face to which type of family tends to actually be affirming and show up. It really has a lot to do with the process. And so similarly, let's say someone's trained in adolescent psychotherapy and they're great at it. And they have all the tools and they know how to work with depression, anxiety, and identity, and learning and all of that. But they don't necessarily have training in family work, right? It's assumed, but the family work that's required in gender care is not say hi to the person in the waiting room and check in with them and let them know everything's going okay. It's really actually that you're holding the family in terms of their level of whatever's going on with them, spinning out need for information and support so that they can better support their child. So I think we all know that conceptually, but there's a pretty wide range of how that actually looks in practice. And so I just, I do have a very strong position that, best quality gender care is being done from a true family model. And it doesn't mean that everyone needs to be in the room at the same time. It means that you're keeping all the members in mind and kind of assessing the whole needs of the system ongoing. So it starts right away, right? I mean, everybody needs to know. What are you having? What are you having? Yeah. So why does everyone need to know? Because you can't go to Target and go shopping until you find out, because you're not sure which color to buy, right? So, it's like, again, it's like sort of like this habit that we're just in. And, the idea that you dismiss someone being excited and want to have those conversations and have their little lunch and buy their little things, like, I don't mean to be flippant about that. Like, there's a lot of symbol and meaning and richness in that process. But the question is, like, is there room for slight edits that would expand the opportunity for all? And do we kind of move toward that way too quickly? Okay, so I already talked about that. So gender identity. Gender identity at its core idea is, how do I feel inside my heart? What is my sense of myself at a core level, at an identity level? Okay, so even as things like our preferences change, our interests, if you really think back over time, you've been there, right? Think about yourself and think about, oh yeah, oh my God, I can't believe I did that, or I liked that, or I said that, or I was spending time with that person, or I made that decision. But those are all sort of the enacted expressions of, kind of doing the best you can at that moment and kind of making sense of your world. But at a core self level, even if the expression or somewhat of the choice changes, there's still a felt sense. And so the idea here is that that doesn't connect to genitalia or physical body or anatomy, that it's truly just, how does this person feel inside? And even if it's a small group, and even if it doesn't make sense to a lot of people, there will be really, really young children who are very, very clear from the start, like, God made a mistake, or like, when is this part going to start growing on me, or what's wrong with you people? Why do you keep calling me a girl? And it's just like, it just won't compute. They're really, truly like just living the identity, and it's only when they're interfaced with from an outside response that feels wrong and misattuned that they're like, what? So that's, and that's an example of like, the distress isn't necessarily living inside. It's happening once the response happens. Not always, okay, but yeah. So how do I feel inside my heart? What's my style? What do I show the world? Sometimes this is gonna match with how do I feel inside, and sometimes it's not gonna match with how do I feel inside. I could feel like a boy and just like that sparkly shirt. I'm not questioning gender, I'm not stressed out, there's really nothing going on, I like that shirt, right? And then somehow everyone else got the memo that I'm not allowed to like that shirt, and I never got the memo, and I just like that shirt, and now everybody has an issue with it, okay? So you can see, like, let's say like a young child like likes these like sparkly light up sneakers, and then everybody gets all anxious, like it means this, it means that, they're this, they're that, including like sexualizing them. Like they're a young child and we're already worried that they're gay, or they're gonna do this, or they're this, or their life's gonna be so hard. And they're like, hello, I just like these sneakers. You know, it's like, and if you think about it, like, again, like, you know, if I was in the preschool dress-up box and there's like this, and it's a hot day, and there's this beautiful, sparkly, flitty, light tutu, or there's these like Carhartt like work pants, and I like get to pick which one like seems more fun to put on and play and pretend. Like, you know, it's not unheard of that someone who happens to be born with a penis might like the tutu. But again, there's like always this kind of very quick, you know, anxiety and panic about what that means. And the point here is really, we don't know yet. You know, the jury's out. So like these kids, like I joke, like this kid on the right, like could not be more excited. You know, this little ginger is like, this is my dress. But we don't know that this child's transgender or gay, or this child likes this dress. Right? Now, it could be that every day this child's like, but I'm a girl, what's wrong with you people? Like, let me do this, let me do that, you know, and so that's kind of where, like, based on the response, is there distress or not, okay? And then sexual orientation is who do we love, who do we date? You know, this comes later. Even though you know, a lot of people have had these conversations and talked about these topics a lot, they still get gray and confused. Gender identity, gender expression, and this sexual orientation. And, you know, and again, it's like, you know, you just have to keep kind of thinking about it and talking about it, and it's specific to each person. But, you know, these terms continue to grow and expand and change, and so you'll kind of never be current, but you just get as current as you can. Yeah. And really the best thing to do is just ask someone, and then they'll tell you how they're identifying, and that's really the gold standard. Okay, so transgender, general term for people whose identity, expression, or behavior does not conform to that typically associated with the sex they were assigned at birth. Transgender used to be thought of even more as like a binary, like I'm a trans woman or I'm a trans man, I'm a trans girl, I'm a trans boy. And what that means is if you were born with, like, you know, stereotypically female genitalia, for example, and then you identify as male, you're a trans boy, okay? If you're born with a penis and you identify as female, you're a trans girl. It's like the opposite, right? So, but a lot of people now, especially young people, are kind of claiming a general, broad transgender identity, even if they feel more like both, or neither, or mixed, or fluid, or non-binary. So there is non-binary that's a separate kind of term and understanding, but some non-binary people will also grab transgender as part of their identity, and they feel like it's both. Non-binary. Also termed genderqueer, fluid, I feel like both, I feel like neither. Sometimes this relates to the inner experience and how someone's kind of understanding themselves with identity. And in addition, particularly with youth and adolescents and young adults, they sometimes grab it more as sort of like a political like statement of like, I'm gonna refuse to like be categorized. Like we shouldn't have to exist in this way. It's like, oh, it's just like a concept that other people have put on us. Like they wanna decolonialize gender. Right. So that can be going on too, but it's, you know, typically, even if someone sort of lives and breathes like an activist identity, there's often also like an actual gender identity that they're either questioning or feeling clear about. Cisgender. That would be someone who's born with physical anatomy and birth sex and their inner identity and matches up, okay? And the reason it's important to include cisgender, you know, the example I like to give is sort of the television news. Like, who do we find out about that committed a crime? We only hear about the race, for example, when it's not someone who's white, right? It's like, and so it's the same thing here. It's like the reason it's helpful to say cisgender is because you're moving again toward, that's one of the choices, that's the variance, cisgender, transgender, non-binary. It's a broad variance and a sweep, and not like cisgender is normal and then everything else over here. And so you're, you know, it's a strategy to not other as much. So when you own a cisgender identity, it's actually very affirming to other people, and that's why you would do it. Okay, so let's see. I can look at those. A lot of people worry that kids are too young. So, in the example I'll give is basically when, if there's a 3 or 4-year-old and they're saying like, and they have a vulva and they're saying, I'm a princess, I'm, a girl, I'm a sister, I'm a mother. No one's like, are you sure? How do you know for sure that you really feel like you're a girl? Like, you're too young to know. No one asks that. They only ask it when there's a variance, right? And so is it really about the age and the worry about the age that they're too young to know, or is it about some sort of unconscious transphobic anxiety because it's not applicable across the board. So it's just important to sort of notice those automatic responses, and that logically makes sense that you feel worried about someone being too young, but we don't see the application when it's kind of what's considered normative. Okay, within kids that are fluid, 85% over time identify as like gay or lesbian or nothing, or it's the kid who liked to climb trees and play with trucks, and just like it's like if they just had room and permission to be themselves, it doesn't translate into some LGBT identity. But within the 85%, 15% will identify as trans, and so even though it's a smaller group, they are the most at risk, right? And if you look at the kind of bottom line most at risk, it's trans women of color, particularly Black trans women, and they're being murdered on the daily. So it's there's high levels of violence and marginalization and rejection and homelessness and all of it. And so the reason that this area of care is so crucial is because the social welfare issues are paramount. It gets a little more confusing when, not confusing, but there's we're in a time where the population isn't just a young person or a young adult who's been rejected and kicked out. We have those too, and we're serving them in the city and county, right, all over the clinics. And so San Francisco has done a good job for many, many years with that population. But they tend to be teens and young adults who are in that status. And then this newer group is families where the children are actually intact and at home and everybody is still stressed out. And so it's a little bit different area of care. They have psychiatric needs, they're not being asked to leave the home, but then there's a lot to sort out in terms of how to best support them. Even if the family is affirming, how are things going at school? How are they feeling about themselves? How are they dealing with the changes that are happening to them in terms of like puberty and things like that? So there's, so over the developmental life course, there'll be different issues that arise for children. Even within a family system, it's not enough that the family's just supportive. There's unique needs that come with the trans population. So the first step of that is this idea of social transition. And what social transition means is you're not anywhere near any need to think about anything medical. You're just deciding, are we going to support this child in who they say they are or what they want or what they need? And so they'll say things like, but I want to be called this name, or I want these pronouns, or I want to be able to wear these clothes. And so those are not medical interventions. A lot of families will feel nervous if you do that. It's like the first step to allowing like this speed train to like full surgery, right? And again, we tend to, it's like a human habit to kind of like jump from the A to Z and catastrophize and worry ahead. And it's a well-meaning worry because you care and love your child. And so understanding that anxiety is often coming from a good place. But there's really no data that supports poor outcomes if children are supported in what we call the social transition. And then if they realize that's not what's happening, it drops, or they change their mind, or they want to take a pause, or basically all that happens is that, right? So if you look at the sort of psychic experience, it's like if I was supported in what I said I needed, and then what I needed changed, and then I'm supported in that, that's actually more continuity than we'll support you if. Right? Because then if you think about that, there's more condition around like, well, let's make sure first. Let's see all the evidence lined up to prove that you really need to wear that pair of pants, right? And so that's where, in the privacy of the family work, there needs to be room for the parents' like grief and anxiety and things like that. So within like a clinical model of working with the family, we'd want some room to really allow their feelings and have room for their worries and concerns, and then also be able to give them information versus kind of like an anxiety-driven like decision, right? But again, a lot of people focus on social transition as like child abuse, and the medical interventions as well. But with this, what's so interesting is like a lot of these kids are nowhere near medical intervention at all, and the level of worry is as if they're like on the surgery table like that day, right? And so helping the family get their reaction into right size is also helpful. Okay, so I just said this and we'll skip it and I'll send the slides. Family system thinking, I'm talking a lot about that. Child and adolescent team knows what that means. But it's things like, let's say it's a really affirming family, but there's different personalities, right? Like let's say my child has a different sense of privacy and sort of social personality than me. Oh wait, that's actually true. I just said about my, right? Like, don't post that, don't post that. So like, it's like that's where conversations need to happen, right? Like you're going to the holiday meal and like, was there some like announcement that the child doesn't even know happened, and then everybody's like kind of looking at them like, right? And we know children don't like that, right? Like if they've been having a hard time, if they were in psych hospital, if they were, if they're like failing out of school and like everyone somehow got the update and they don't know, and then they arrive and then they can tell that they're being interacted with in a different way, right? And so this would be like an example of the conversation that would happen before that you try to scaffold kind of the decisions and make decisions together in the planning, that the child actually has rights in terms of saying like, I don't really want people to know yet, or I want you to tell them, I don't want to have to tell them, things like that. So it varies in terms of what people want, but the point is that you're working together around, there's the, like any extended family or extra support systems or places that this person's going to interact. Okay, so we get the idea, you're male, you're female, you're masculine, you're feminine, you're attracted to women, you're attracted to men. And really what we see is that each of these areas, this is a little bit of a problematic tool, but I'll get into, if you want to know more about that, you can let me know. But the only reason I still include it is because I like that it breaks down all the different areas and shows that they each sort of live on their own continuum, and that they may or may not overlap. So like we said, you might have a core identity. Let's say that I was born with a penis, and inside I feel female, but I am terrified and I'm not going to tell anyone about that. And so I'm presenting like super masculine. Like my expression wouldn't give you any clue about how I actually feel inside. Where someone else would feel like that level of internal compromise is too distressing, and they would push and kind of wear what they want and do what they want and take the distress of the response over the internal distress. And so that really varies in terms of each person. It also varies in terms of anti-bias work and how you think about families, and it's a very Western white kind of upper middle approach to like push the individual identity expression, and like, but you need to tell everyone, you need to feel proud, and you need to, like really no one needs to do anything except what they really need to do for themselves, right? So for some, the mental health picture is really distressing and they're really symptomatic, and we would want to kind of explore, I know you say you don't want to, but you seem miserable, and like you've been suicidal for 2 months. But at the same time, it's not really our role to push an agenda of readiness or pace. And there are cultural variables where someone doesn't want to push, like the elder system, or they might have a pulse on the level of risk or rejection that's real and they don't feel ready. And then sometimes there is the developmental reality of they're just really, really nervous, and they'll say that kind of flippant, like they'll kill me, they'll kick me out, and it's nowhere near true. And then you can kind of wade through those weeds and see if there would be room for some type of a conversation with the family. So it's never all or nothing. But to me, that's an example of where the heart of the family work actually lives. It's like you can honor the kind of, do like almost like a harm reduction and like motivational interviewing readiness kind of approach to where someone's at around the process, and then just try to understand what their fears are about making certain choices or not. And then you're balancing that out with how they're doing and how they're actually functioning. And if there's a big discrepancy, then you have that conversation too. But this is kind of where, the gender care world thinks about this more. It's kind of like everything overlaps. Some things are overlapping and some things are independent. Okay, so I wanna, hold on. I'm gonna come back to this because we don't have a ton of time. Look at these cuties. I'm gonna come back to these, or you can read them later. This is my kid. This is my kid Ruby, and my son Xander. Of course, the irony was like Xander loved pedicures. Like he never got the memo that you're not allowed to like pedicures. Put your foot in a warm bath, choose a sparkly color. Like, what's better? Just get a massage. Like he's like, yeah. And Ruby's like, do we have to go there? But Ruby could not have been more happy with this Peter Pan costume. But I'm telling you, she was panicked in her kindergarten classroom, hiding in the bathroom, crying, worried that everyone would make fun of her costume, even though she really loved it and wanted to wear it. And she just totally panicked. And so she was like very gender fluid. And when she was little, she would say things like, I wish I had a penis. Boys are more colorful, boys are more powerful. And Ruby's Ruby. She doesn't identify as trans. She identifies as female. And I was wondering, like, when puberty hit, if that would change, if it will change. My job is to just believe her and listen to her for now, and it hasn't changed. And then other kids will be like, no, like, this is really happening. And so it really varies. This is them again. So, and then there's this group, we're not going to get to this whole concept, but I'll tell you about it, which is called Rapid Onset Gender Dysphoria. And it's a group of, it's a concept that's unscientific, but there was a paper that came out of Brown by a woman named Lisa Littman, and she tried to coin this concept that young people are on social media and then they get influenced and then they think they're all transgender. And then gender care providers are like, oh, okay, you're transgender, sure. Like, get you scheduled on the surgery table and like get you medicines like immediately, right? And so it's just like that's kind of how the narrative gets spun, is that there's this like agenda to make everyone transgender. And what it actually seems is like the developmental norm for a young person to seek information and find connections online. So you see a family that's like, their narrative will be like, wow, my kid is so resourceful. They didn't know anything about this. They knew they felt something, and they started looking, and they found like a community, and they found information. And so the same exact adolescent behavior of searching and connecting will be spun differently based on the feeling or meaning that got made within the system, right? So for one family, they're like, wow, my kid is so resourceful. They found information, they found resources, they found connections. And then for another, they're like, oh, they're just a follower, they're following everyone. They never said anything about this before. Some of the reasons that we don't see, and so what this presentation that I call is later out. It's like, this is not the kid that was 3 that was saying, like, what's wrong with you people? Didn't you get the memo? Like, I'm this, I'm that, right? They don't realize. And part of it is that another point of onset is often the pubertal development. So, you get to kind of just live and be and hang out under the radar for a while. But when the body starts changing, that's often a time of a new wave of distress, because then it starts to feel like, some betrayal around like which direction you're headed. And you might not have had awareness before that, but sometimes those body changes are actually what triggers off the awareness. So we'll see like a number of kids that are like middle school age, and those are often the ones that have like the high acuity mental health presentations into adolescence, or they'll start to tell people, or they won't feel ready, and then they'll get really symptomatic slightly down the road, like 14, 15, 16. So we'll see a lot of those young people as well. So the family has a range of feelings, and caregivers also. And providers also. And so it's a lot to wade through, and we won't have time today, but basically you get the idea that there's sort of these two camps. The data on family acceptance is clear. And I'll give you an example. There's a statistic in the adult trans population, which is that a person who is fully connected to their family and accepted and close and in close contact, and a person that attends their holiday table once a year, those two people are doing more closely similar, that's a double whatever, they're doing more similar than the person who's fully estranged or rejected. So even if people are having a hard time, it's not their favorite, they don't know how to understand it, sort it, accept it, there's still, if there's any level of acceptance, we see a better prognosis in the person. So it's not that families have to be perfect, it's that they love this person and that they're not completely rejecting them. And so I thought that was really powerful data, and it leaves a lot of room to work with families and try to help them understand how to be affirming and show up. And you can look up this if you want. The San Francisco State, the researcher that's been doing this forever is out of there, and so it's familyproject.sfsu.edu or /edu. High rates of violence. We're not gonna be able to go too far in. I'll talk a little bit about dysphoria because it is the clinical diagnosis. So one is of the body. There can actually be distress. So someone could qualify for the diagnosis of gender dysphoria based on actual distress, and the places, when you're doing your assessment, the places that you see that are in sort of the rhythm of the day. How are they dealing with a shower? How are they dealing with getting dressed in the morning? What happens when they catch themselves in the mirror? What happens when they start to over worry about how someone else is looking at them in the hallway at school, and so on. It can also be things like misgendering. So, you ask the family, please call me this, or please say this, and then they won't do it, or they say they'll do it, but they keep having trouble being consistent, to, extreme like refusal or outright harassment or bullying, which can happen also in the schools, or in the peer cohort. Another form of dysphoria can be sort of a high level of comparison to the peer group. This can particularly happen at development, right? So if you feel like a girl inside and then, you're watching all the girls develop, or you feel like a boy inside and all the boys are getting tall and like robust, and you're, feeling like you're instead developing like breast tissue and, having your period. And so that's where a lot of that comparison, it's not living in just adolescent development level of awkward, insecure comparison. It would be like crank the volume up on that, and there's an extra piece very specific to gender. The risk for those areas can also happen with things like eating disorders, because there's a lot of focus on like, where does the fat get distributed? How does my body look in my clothes? And then that drive to kind of control the behavior based on that can develop into eating disorder behavior that kind of becomes its own presentation in addition to gender, although it was fueled by gender. And similarly, historically, to if this person is using drugs and alcohol, they have to get sober before we can treat their depression. Like, that just doesn't work, right? You have to actually work with all the things at the same time. And so one of the points of assessment, if there are eating or body-related issues, is where does it overlap with gender or not? Same with depression, same with anxiety. I'll go there for a minute to show you how I think about this. So here's like kind of the basic way that I think about these kids and families. One is the gender health. And the gender health would be, how do I feel about myself? What's the level of dysphoria or not? And sometimes kids are actually doing fine. It's more of just the response they're getting that's causing the distress. And then other times they're having real distress, like, I wish this wasn't true. I wish I was just cisgender. I don't want to deal with this. And their depression is kind of fueled from their own, right? Or they grew up in a family where like the church is very important or something, and then they have this huge internal conflict about where they're going to fit or if they're going to be like, rejected, and they're scared. So gender health can vary. But it's not always that gender health is poor. Sometimes it can be okay. Mental health. Is it fueled by the gender health issues or not? What if depression runs in a family, and even if you have all the right care, you're totally supported in gender, you still have depression? So part of the work is also helping someone be realistic and helping the family be realistic, that there's not a perfect cure. Because sometimes if there's a high level of symptoms, the family will be willing to take certain steps because they're worried about their child. But then when they see that their child is still depressed or still self-injuring or something, they're like, see, it wasn't this. You insisted that we should do these steps and it didn't even work and you were wrong and that's not what this is. And what it actually is that it can be both. It can be, and so understanding the sort of genetic predisposition, understanding the history of the presentation and how likely that would persist and need to be supported and managed independent of gender. And then at the same time, would we see symptoms reduce if we were supporting the gender? The feeling is yes. If you have a very full plate and you're able to remove something from it, it's going to be lighter. But it doesn't mean that it's completely solved. And so it's more about helping someone be realistic. Whereas the family system, there's no dichotomy of a supportive versus an unsupportive family. There's a variance in how people are managing and thinking about it. Sometimes, yes, at the core bottom line, there could be actual abusive practices, kids that are at risk. But again, I think there's a much wider range of places to work and support a family before that's the case. And so that's kind of where the gender work exists. And then development. Development is not just about understanding the child kind of in that phase, but it often gets used as a weapon against someone saying they know who they are. So just sort of like an ageist or sort of, like an ageist approach to, well, you're too young to know. But it can also be things like, if I say I know who I am, but then I act impulsively and make a poor decision about something else, or I'm not doing my homework, I somehow don't know who I am. And it's like, no, you know who you are and you're not doing your homework, right? Or like, families will feel like, what do you mean I just let my child decide, right? Like it goes against the majority of traditional parenting frames and models. Like, I guide my child, I offer wisdom, I provide the structure. And so you're like, let them decide. So parents hear that as they're supposed to throw their hands up and relinquish all like parental influence. And I always say, if my child wants 20 cupcakes, like, I'm not gonna say yes, and I'm gonna still make them brush their teeth and do their homework and go to bed and do all those things. But that's different than when they say, like, this is happening inside me and I need you to listen. And so a lot of times they'll be like, well, you wanted a puppy and then you didn't want a puppy, and you wanted to play the violin and then you didn't want to play the violin. And so this idea of core identity and self and sort of self-assertion of this is going on will get conflated with that range that can happen around you're learning who you are and you're trying things out and figuring things out. And it's not that the gender presentation can't vary too. But again, the point is, when you go with where someone's at that moment, there's really no data that suggests that there's a negative outcome to support, because you're right where you are, and then if it changes, then you'll go there. It gets a little complicated, obviously, when you're making a decision about medical intervention, which, if we do part 2, we can talk about that. And then the other piece I'm just going to show you is, just these confusing messages. It's like, kids are sort of unapologetic about what they're going to do. So like, I'm a boy and I like this dress, deal with it, right? And the parents are like, wait, what? Or this one, I'm atheist, give me Christmas presents. I was like, well, of course they're saying that, right? Like, the idea that would be used as like evidence that they don't know themselves. It's like, no, that's where development lives, and like it makes sense, and then at the same time there can be more to it, right? You've changed. Well, yeah, we're supposed to. So the point is, age is only one variable. So development is important, but again, if you look at that kind of assessment idea, it's like they're all overlapping, and then the family work is really about attachment. It's really about like, we don't see a certain face of who shows up for their child. There are people in really, really small towns. There are people in very specific cultures. There are people in very religious communities, and they figure out how to do this. And it's scary and it's stressful, and they have more variables to manage, but really it's like, is that juice there? Like, is that parental muscle there? And when you see it, that's where you're spending time. So it has a lot, from a clinical application, it has a lot to do with focus on attachment-based work and sort of the trauma of rejection. And what I was gonna say really quick, so because of that, we think a lot about ACEs. Like, I feel like, the level of, so you think about, like, there's a family who has like a two household, like there was a divorce, and that's listed as an ACE. But then this type of level of rejection and like what kids and families are managing in like all the systems is not. So I'm just like, I'm gonna call Nadine Burke-Harris and be like, that's the bullet. So really this is what we're dealing with, right? It's not just those 4 areas, it's all the areas. The larger macro level isms, communities of color are more at risk, and then you add the phobic, and that's not because that family system or that religion or that this, it's because of this larger reality that there's a level of tolerance for that type of violence. And so the idea that it's not impacting, just doesn't make sense. So I really think about it this way, which is, and then whatever else we'd add in that isn't even listed here. Okay, so you get the idea. Let me look at the time. Okay, I'm going to pause and see if there's just any quick questions since we're really running out of time. And then you are welcome to reach out to me. Because it's only an hour, so here we are. Does anyone have any questions or any quick examples of kids they want to ask anything about? Yeah. 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 Yes, right. Yeah, that's a great question. So the question is, how do you support the school system in being more affirming? Okay, so it really varies. I mean, at one level, I would say it's very similar to sort of like an IEP advocacy process, right? For some schools, they just don't have enough information, and when they get that information, they're happy to be on board, right? And so in that place, you can do the tips and tools and recommendations. And then in the system that's really pushing against and saying, well, we just can't, right? Like if someone is named Michael and on the roster it says Michael and the kid says, I'd like to be called Mike, no one would say, but I'm sorry, but legally it says Michael, we have to call you Michael, right? So there's ways that schools will sometimes use like what they say is the law to sort of be unaffirming or deny, and it's actually inaccurate. And so those systems, or like a refusal to allow like access to a certain bathroom or locker room, and so there's the side of the continuum which is actually the laws, and then those schools need to be kind of pushed and updated that those are actually laws that are protecting. So the way to do that is really the most effective voice is the family. So whenever possible, you're working with the family too, right? But otherwise, you go bottom up and top down. Where's the power? You want to spend time with the administration and kind of say, and it's not about like, oh, you're doing it wrong, you're horrible, you're unaffirming. It can be like, let's take a pulse and sort of evaluate, how are you doing as a setting, right? Like we can all do that. Like, how's my waiting room? Do I have like signage? Is it welcoming? And so it can be things like that, like basic sort of institutional approach, which is like, do I feel like I belong here? Do I feel like I'm represented, right? And then at the same time, but I'll say specifically, SFUSD has a really good LGBT department, and they'll come and do trainings, and they offer like they're called Q groups, I think. I'm not sure which level of school you're in, but in the middle schools they're doing those groups, and in the high schools. And we go and train the counselors and social workers and nurses to kind of increase their capacity. And some schools are better than others. And so part of it is also consulting with that department, and if needed, for them, like if a school site needs more training, But also if it's really dire, then also finding out which schools are doing a little bit better job and see if you can advocate for some type of a transfer. So there's that. In younger early childhood settings, it's a lot about normalization and visibility around the variants, right? So it's like, are there representation of like books and supplies and things like that for young children? And then the other thing is, you know, systems worry when there's going to be a complaint. So, you know, reminding them that like it actually impacts the mental health picture is kind of really the conversation that needs to be happening. Yeah, I'll stop there for that. Any other questions? Yeah. The question is, how do you involve the family and what does it look like? Yeah, I would say it varies, but I tend to work in combination, and I'll just be really explicit about why. You know, so I'll say, you know, like you need a right to sort of have privacy and feel comfortable and safe, but actually, what if you need something from your family? Like our goal is actually to help them really understand what's happening with you and get better at that, right? And so part of the assessment of gauging how to decide what combination or structure you're going to do is really partly where the family is at. So like, where's the caregiving system? If they're really struggling and then you want to reduce kind of the level of exposure of rejection, then you might be spending more time privately with the parent or caregiver to give them more space to say things that the child shouldn't really have to hear, right? And then, but usually I work in combination. So if it's you know, initially you do everyone together and then break up in different combinations, see the young person alone, see the parents alone, and see everyone together. Yeah, and I think it's, in my experience, it's just true for particularly adolescent work, that there's this assumption that the teen needs a lot of time and space by themselves and that developmentally they need all that privacy. And it's not that that's not true, but I think people overreach that focus in the treatment. And you know, you're not going to be in the picture forever, and really our goal should be to bridge and kind of repair those connections and relationships and deal with attachment in a developmentally appropriate version. And so they're all hungry to kind of know that they're there for each other in whatever version. And sometimes there's abuse or like very high conflict or it's really inappropriate, but you'll know when that's the case. And a lot of times it's more, but I really think there's a lot more room to kind of work with the caregiver and young person together than we sometimes spend time doing. We might have to be done. Okay, just to respect people's time, I'm going to close, but I'll stay up here for individual questions, okay? Thanks, yeah.